let me just focus on the diffuse instant restenosis. This, we are all aware of this slide that is by Mehran, and the type 4 is diffuse or chronic total occlusion, where I am going to discuss about the case examples. This is more than laser. I am just going to give a brief approach on management of instant restenosis, and this is the latest algorithm. With the increasing number of imaging guided PCIs, obviously, we need to focus more on the pathological mechanism of the instant restenosis. And obviously, whether it is based on the mechanical issues or stent-related mechanisms or biological, like neoatherosclerosis or NIH, we need to strategize our plan, especially the adjunctive therapies, whether we need to restent it or need to do a DCP in these cases. We go to the clinical history. This is a 47-year-old male with a couple of comorbidities, CKD stage 3. He underwent PCI to LAD as well as OM with 2 overlapping stents in 2019 for NSTEMI. He again underwent a primary PCI to LCX PDA, that is after the OM, due to acute inferior MI, now presented with FR3 angina, mild LV dysfunction. This time, 2 months ago, I did a check angiography. The stent in the LAD was pattern, whereas the ostial OM has a critical stenosis. You can see here, ostial and also the LCX, the distal LCX PDA got totally occluded. This is the scenario. And we all know this recent algorithm again, they are based on the angiographic morphology of the extent of occlusion of the CTO, whether it has occluded within the stent or beyond the edges of the stent. There is a pattern A to D. Based on this, the success rate of this procedure also varies. And our plan in this case is not merely antegrade wire escalation, obviously long segment occlusion. If we have some challenges, so we wanted to go for a hybrid approach, both antegrade wire escalation with the crossbars and also atherectomy with laser and specialty balloons. For the LCX OM, we wanted to do a provisional bifurcation stenting. There are challenges in this long segment CTO-ISR because when we do with the hard wire, first of all, the proximal cap is not like a native CTO. It will be very hard. Obviously, need to penetrate it with the hard wire. And tracking only with the wire may lead the wire understud. So we need to have some device, blunt device, which needs to go into the distal edge. So you can see here the CTO is a very long segment occlusion, very long overlapping stents. So what I did, the proximal cap I have penetrated with the concave screw with the microcatheter. I think it is a fine cross or something. Then after advancing this wire for some time, obviously it went under the stent. So I had to go with the crossbars here because this is the one indication in the APCTO that crossbars for the ISR. So this is just a demonstration. And then I just put the crossbars. If you see the crossbars is going up to the distal LCX up to the bend. Beyond that, being a high-profile device, it was not advancing beyond that. At one point of time, the entire PCI system was backing out, so I had to again exchange with the antegrade wire escalation here. So I just again wired it. Luckily, the wire went into the distal true lumen, but again the challenge is crossing with the microcatheter. Neither the microcatheter that is coarser or my small balloon didn't go through. Then I had to use the laser. Luckily, we have a laser system in the hospital, so I did with the ELCA. Then ELCA was done, and as Deepak mentioned, with a very slow advancement, 0.5 millimeter per second, with up to 80. There are some off-label uses of ELCA within the stent. You can do it like without giving a saline or without, by mixing with the, saline also you can do it. This is all the theoretical part. I don't want to go into that. The only thing what you have to understand here is the laser, as he mentioned, it acts not only axially within the lumen as well as the abdominal tissue, as well as linearly. So it can penetrate up to 50 millimeter in the longitudinal direction. So this is one tool which will be useful in balloon undilatable or hard block. And these are the 5 things, as he mentioned, we need to remember whenever we are doing the laser. This is a study from neurointervention which has showed in any stent under expansion to crack the peristent calcium, laser is useful. This is a very small subset of study from China which showed that the laser can be helpful in ISR CTOs. It shows improvement in procedural outcomes as well as the 9 months outcome, both in safety and efficacy. Coming to our case that the patient has under expanded stent here and a lot of neoatherosclerosis. Then we did a scoring balloon. As per our Desire 2 trial, the scoring balloon followed by a DCB is better than plain NC followed by DCB. So we did 2 drug-coated balloons there. And then the final result, and did a provisional stenting the OM, the final kissing balloon and part, and the final result is like this. You can see the carina and the above LCX OM, and also the longitudinal L mode, you can see the tissue has been totally ablated with the laser. This is the one interesting thing when we use laser to vaporize the restenotic tissue, and the final angio looks better. This was a very long segment occlusion, so I think this laser has helped in this case. Coming to the second case, again, this patient had a couple of comorbidities. He had a LCX OM stent, which is an undersized stent. After I did the imaging, I saw that it is an undersized stent. And here again, the patient went in for a LCX OM CTO bifurcation. You can see this is a very tricky CTO because it is a downstream of the LCX. Obviously, LCX for all CTO operators, LCX CTO is actually scale, and also at the bifurcation. So the wiring was initially a bit difficult into the OM, but somehow with the escalation, de-escalation, we were able to wire it, and then we dilated to flare the ostium of the proximal stud of the stent so that we can wire the LCX, because there is a big OM too. You can see there is under expansion here, and the ostium of the LCX has a lot of new atherosclerosis. Then I was trying to wire to the LCX. As the previous speakers talked about the dual lumen catheter, the Crusade was really helpful in pushing the wire into the LCX. Initially, I was trying with the filter XT. It was not working. Then GAR2 finally changed to cyan wire. Again, the challenge here is even the 1 millimeter balloon could not cross because of the tortuosity and the tissue which is formed inside the stent stud. So I had to use some laser energy across the proximal stud of the OM stent before taking the balloon again. And then after doing a laser, the 1.5 balloon easily went in. Then we dilated the proximal stud. And then this time I dilated again the OM, and then with the DZB after laser and pre-dilatation and DZB of the OM. Now what I did, I had to put the stent in such a way, because there is no proximal landing zone. It is almost like a modified flower petal technique. So I guessed I have gone through the lower part of the proximal OM stent and dilated it and put the stent, and then finally did a kissing balloon. So the result was okay. And then we did the OCT. You can see the LCX ostium nicely expanded, as well as the LCX. You can see the 2 layers of stent studs across the LCX OM bifurcation. The conclusion is, in any diffuse instant restenosis, we can't stick on to one tool. Obviously, there are 3 things we need to understand. One is imaging guidance. That is the very, very important thing to understand the mechanism of ISR. Number 2 is the atherectomy, proper debulking of the device before putting a restent or doing a DCB. So proper atherectomy or atheroablation only will increase the acute luminal gain. And we have to again check it with an imaging. And ELCA here is useful not only as a balloon uncrossable or undilatable device, also it vaporizes the tissue inside so that the acute luminal gain is increased, which is obviously translated into late restenosis. And dual lumen catheter, as previous speakers told, is a very, very useful thing in crossing the side branch in difficult complex bifurcation lesions. And DCB, though there is no robust data, there are emerging indications, in fact, in diffuse instant restenosis as well as in multiple stent layers instant restenosis. Thank you.
Yeah, thank you, Dr. Dhamodaran. Nice cases, very illustrative. Regarding instant stenosis, I mean, now, normally whenever we think of only doing POBA to instant stenosis or dilating balloon, often we end up in stunting because of intimal hyperplasia, where flaps form post your balloon dilatation. I think laser,
Yeah.
by evaporating it, so leaves a very pristine area so that, there is no need to stunt again. But do you think, see, LMCA bifurcation, the plague in LMCA bifurcation today, I mean, in short run, most of the trials showed PCI is almost inching towards CABG. But only area where PCI is struggling is the restenosis rates of LCX.
Yes.
And the restenosis rates are almost like 15 to 30% based on 2-stunt, 3-stunt strategy or single stunt strategy. Do you think, can we slowly inch towards a kind of lifetime management of LMCA bifurcation with laser?
You mean to say post LMCA PCI with restenosis?
No, if patient gets restenosis, do a laser, do a drug-eluting balloon, again restenosis, do a laser and drug-eluting balloon.
Yeah, nice thought, and in fact, my approach to LMCA PCI is almost like more than 80-90% provisional only. I still follow Goran's rather than Chinese philosophy. So unless the patient goes in for complication like bailing out, usually approach and whatever DK crash, they told the data is superior. Still, I feel the provisional approach is better. And some of the cases where I feel some dilatation should be done in a provisional, this one, and I usually do a DCB in the first time itself, final kissing balloon with a DCB. I don't have much data except on some small trial from China which has shown that DCB in the LCX ostium in the first time itself can give some good results. But that's what I will be doing. As you rightly told, not only for left main with the restenosis, any kind of restenosis, this is an adjunctive tool. The only mechanism, what they are telling is, it is ablating all the restenotic tissue. So we will get a good plaque volume reduction, and but in long term, we don't know. Long term data is not much available. Especially diffuse ISR, no long term data available.
Thank you, sir, for the laser guided plate PTCA. So I just want to know if you have got an instant restenosis, among the different debulking tools from cutting balloon or scoring balloon to your lithotripsy to the latest laser now, how do you choose, or if it's available freely, how will you specify which is to be preferred over, like a focal restenosis, diffuse restenosis, thrombus without thrombus or a diffuse intimal hyperplasia? Can you specify any of the ways to?
Yes. For any restenosis, two things is very, very mandatory to me. One is stent boost, stent enhancer, which will give you the evidence for a stent gap or stent fracture, even though imaging can do. The second thing is to understand the mechanism. Though angiographically it may look properly expanded, if you go with the imaging, it will be underexpanded. Without imaging, I will never do a ISR because it's the second time. We are doing a second procedure to the patient. So I am telling the typical ISR. So after doing a imaging, we will understand what you need to do. If it is an under-expansion, you can just expand it with the help of a high-pressure balloon, or if there is a persistent calcium, as the previous speaker told, you can do a IVL. Once you expand it, there are indications for DCB, there are indications for restenting. Only one trial is telling EES is better than DCB. Otherwise, of late, there are emerging uses of DCB. I am a favorite of DCB. I have got some follow-up also with DCB in instant restenosis.
I'll add a couple of things. You asked about when do you select laser in such situations. See, it's again based on the pathology. If the pathology is predominantly intimal hyperplasia, so then I think that's where the laser comes as a rescue. So, and if the pathology is under-expansion of the stent, and the reason for under-expansion is again, if it is calcium, so once you deployed a stent and stent is under-expanded, your options are limited. So again, in those situations also, laser comes to your rescue. You can use IVL, but laser is one modality. So it's a diffuse intimal hyperplasia, under-expansion, where the reason for under-expansion is calcium sitting behind the stent. I think these are the two situations. Probably I would use laser as the first tool.
Persistent calcium should be mild to moderate. If it is severe, obviously.
You have a situation wherein you have crossed a CTO with a wire you have no imaging available, you have both the laser and rota available, what will be the choice?
Obviously, laser. Rota has the stent ablation.
No, there is no stent. This is a native CTO lesion. You have crossed the lesion. No balloon is going. No imaging is available. You have both the options.
No, it depends on the amount of calcium. Angiographically, if you see a mild calcium, you can go with the laser. If it is a severe calcium, you must go with the 1.25 bar. And generally, it may be an extra cautious step. Usually, I will do it with the Guidezilla. In such patients, usually I will do it with rather than getting trapped. If you go up front, you can tackle the complications. And Deepak is good in Rota.
I have the same disclaimer as that of Deepak sir, no direct experience. But my understanding is laser has been around for some 30 years now. But despite Samir Sharma sir yesterday presenting, even now in US, the penetration is 1 to 2% of total calcific lesion therapy. So the subset I could find was, one was when the lesion is not crossed. Even this laser need to just sit on the lesion, need not cross. In such situation, this will work. Second, like underexpanded stent. Like IVL, this does not damage the stent. So underexpanded stent is another one. Instant restenosis, I think, is well described right now. And the initial concerns, because it did not become popular, was mainly due to the perforations and the dissections. But over the years, the same Philips company, now we have smaller catheters with less heat effect and better energy delivery. And the precaution is to start around 30, 40 flows and keep it as a lower rate. And for instant restenosis, we can go at 80, as presented, 80. This other thing I could dig out.
Deepak has nicely pointed out about the huge thrombus. That is another very good emerging indication. You have shown one case, huge thrombus, that is
Dhamodaran, one more thing. One more thing. Could you tell us something regarding the catheter size? We know that 0.9 and 1.4 is the commonly used ones. Do you have both the catheters in your lab, or you have?
I'm only having the 0.9.
And how do you select regarding the fluence and frequency of?
As you rightly told, if it is within the stent, we can go straight away 60, 60, 80, because we are safe. And if we are dealing with the native vessel, I always go with 25. Depends on the lesion morphology. Suppose if there is a thrombus, the laser energy will be absorbed much into the thrombus. So we can go higher, but always start with the lower, then you can go. Whereas if it is a fibrotic plaque, you can go with the medium. For a very severe calcium, obviously, high energy.
Can we have some comments from the senior faculty, Dr. Rastam, Ajit sir?
I have zero experience with laser, but we have a lead extraction program every Wednesday in hybrid room. They're very cautious about the module they have. They don't allow us to move to another cath lab. But those cases where you have laser, they're not usually elective cases. It's like wire crossable device and crossable situation. Now they're going to buy a new module which is more movable, less fragile, and I hope we'll start using it, because the price for laser catheters 6 years ago was 7,000 per case. Now it's 2,500. It's twice cheaper than Shockwave. So I can convince administrators.
Vijay sir, Rehan sir, we'll close the session. Shall we move on to the next session? Thank you so much.